Well, thank you very much for that very kind introduction. It's a real honor to be here speaking to all of you at Grand Rounds at Texas Heart Institute. And I believe we may be making some history here where, for the first time, a hepatologist is speaking before this distinguished body. And so thank you again. So today, of course, is Go Red Day. And I believe it's very apropos to talk about cardiovascular disease in women, which is certainly a big focus of cardiovascular care, but also the fact that within liver disease that we're going to be talking about, there are some very interesting and concerning facts about the presence of chronic liver disease in women and how it impacts on their cardiac function and long-term survival. Now, going back, a confession I have is I was absolutely slated to be a cardiologist dating back to second grade. And my father was in pharmaceutical sales his entire career. And one medication that he was very proud to sell was a medication called Paratrate, and it was one of the first oral nitroglycerin agents to treat angina. And so a drug that was developed back in the mid-50s, he had great enjoyment meeting cardiologists at all of the medical schools in New York City, where he was a salesman, and going to the various conventions and organizing grand rounds with some great cardiologists around the country that he would bring into the New York City area. And all of this as a young kid who had aspirations very, very early on in my life and in my career of wanting to go into medicine. It was so lopsided towards things related to heart disease and cholesterol and angina. And all of these great ads that Paratrate was running in the medical journals, which were laying around our house when I was growing up, had a tremendous impact on me, not only for wanting to go into medicine, but really having a secret appreciation for cardiology and cardiac disease. And my father would always go to the American College of Cardiology annual meeting. This is a picture of him in Chicago at the 1962 annual meeting. And he would always come home with various graphs and pictures and monograms and models that he would give to me as this budding cardiologist when I was in second, third, fourth grade. But cardiology has always held a special place in my heart, even in my career in liver disease. And this was a very, very important Life magazine that I received in September of 1981, right after I graduated college. And as you can see here, they're talking about the artificial heart. And in the corner, these exclusive pictures of Dr. Cooley's historic heart surgery at the Texas Heart Institute. This was extremely, extremely influential on me, where they were talking about the new innovation, the engineering, the biomechanics of all of these devices, and talking about Robert Jarvik and the Jarvik 7 device that he had developed. And he also graduated from Syracuse University, and there was an alumni meeting where Dr. Jarvik in New York City was being highlighted, and had an opportunity to talk to alumni. And I was there, got to shake his hand. And again, one of those real important moments in my time. Now, if you fast forward from 1981 to 1994, when I come to Houston, Texas, to the Texas Medical Center, and we are working hard to establish a hepatology and liver transplant program at St. Luke's, we were assigned to do clinic in the THI clinic, which is still in service today. And we were given basically a couple of rules. Number one, don't get in the way of the surgeons. And number two, move quickly through the clinic. Don't delay the rooms and the patients. And so during one day in clinic, I was with my nurse and she was on the telephone, and in wanting to move quickly, I signaled to her basically, what room do I go into? And she made a hand signal, room number 2 or number 3. So I walk into this room and there is an elderly woman sitting there. And I go over and I tell them hello and thanks for coming today. And before I could say anything else, with all of her breath and energy, she looks at me and she says, "Dr. Cooley, it is such a pleasure to meet you." And I look at this poor lady with her husband there and a bit surprised. And I'm saying to myself, this poor lady does not realize that I am not Dr. Cooley. And so before I could say anything witty back to her, there is a voice coming right behind me saying, "I too would like to meet Dr. Cooley." And I turn around and it is Dr. Cooley essentially in my face with a bit of a smirk and a smile. And I had to excuse myself and tell him, no, I am not Dr. Cooley, but this is Dr. Cooley, and very carefully exit the room. But that built a little bit of a joke that Dr. Cooley and I had together during the time that I worked with him at the THI clinic. So to move forward, I did pursue a career in liver disease, and from the earliest days of my practice and the patients that I was seeing, we were absolutely overwhelmed with hepatitis C. And of course, it is a virus that is transmitted typically through blood contact, blood transfusions, needle use. And it's estimated that there's about 3.5 to 5 million Americans with hepatitis C. And in those early days, the treatment was very difficult. The treatment was not very good, and it was a leading cause of cirrhosis and liver cancer and the need for liver transplant. But it wasn't until sometime around 2014 that the medication Harvoni was FDA approved and really changed the picture here with finally having an opportunity to cure hepatitis C in better than 95% of the cases. But what we did not realize is that there was a tsunami in the horizon. And like all tsunamis, they are silent and deadly. And this tsunami is something called fatty liver disease. And when you look at the numbers of people that have fatty liver, just here in America, roughly 80 to 100 million Americans have fatty liver. And it is, unfortunately, the leading cause of cirrhosis, the leading indication for liver transplant, and a leading risk factor for the development of liver cancer. And the cost of this is absolutely staggering, somewhere around $100 billion a year. Now, with all of our attention to fatty liver and all of its complications, over the past 5-8 years, I have really been giving thought to the associated complications with fatty liver disease and obesity and its impact on cardiovascular disease. And as I'm going to show you here today, this is a real major public health issue. But I first want to take a sidestep and talk about the stigma that occurs in patients with liver disease. And when we talk to patients, or we talk to the public, or other care providers, there is always this sense that all cirrhosis is related to alcoholism, and people get cirrhosis because they are alcoholics and out of control. Well, that is not the truth. Alcohol only accounts for about 49% of all cases of cirrhosis. And when we talk about patients with hepatitis C, there is this stigma that they are drug addicts and the dregs of society, when that clearly is not the case. And even with regard to liver transplantation, we have had this rule, which happily we have been very active in overturning, where if you have alcohol-related liver disease, resulting in cirrhosis and the need for transplant, you were automatically put into purgatory, requiring a minimum sentence of 6 months of sobriety before we would entertain giving you transplant. So there is this stigma that we have against the liver patient. Now, with a result of this, what happens is there is care avoidance and delay in getting the care and diagnosis that they need, which you could only imagine leads to worsening more advanced disease. There is an increased number of people with serious and advanced liver disease because they're not getting the care that they need on a timely basis. And it leads to unhealthy behaviors, which again just feeds back into delays in care and worse disease when we present. We get many, many patients that are what we call late referrals. And we're talking about 5, 10, 15 years delayed in referrals, which could only lead to more advanced disease, increased morbidity, and mortality. Now, several years ago, I was giving a talk in Las Vegas before pharmaceutical executives. So much of liver disease is misunderstood and almost invisible. So a little bit nervous going out on stage. And I jotted down right before I went on, I grabbed a piece of paper with a Sharpie marker. And I wrote down this on this piece of paper. Your mission is to make visible what is invisible. And for me, sharing this with you, my description of this, my 30 plus years of experience, is that liver disease, especially this fatty liver disease, is nearly invisible to the public and to the providers, which is leaning towards later referrals and a misunderstanding. And so fatty liver disease is underdiagnosed and undertreated. And so by definition, fatty liver would indicate that there's greater than 5% steatosis, typically a macrovesicular steatosis we see under the microscope, in the absence of other causes of liver disease. And the caveat here is little or no alcohol, typically less than 2 standard alcoholic beverages for women or less than 3 for men per day. And there is this continuum that you see at the bottom where you go from a healthy liver to a fatty liver, but then that fatty liver develops inflammation. You start to develop fibrosis, ultimately may develop cirrhosis, and then the later complications would be hepatocellular carcinoma. Now, over the last 40 years, and it's hard to believe that we've been talking about this for 40 years, the nomenclature has changed, and I want to share with you the most up-to-date changes in terminology we all need to use. So back in 1980, Dr. Ludwig, who was a pathologist at the Mayo Clinic, published in Mayo Clinic Proceedings 20 cases, a 20-case study report on this fatty liver condition that was not related to alcohol, and he described it quite accurately. Now, from that point, from 1980 to about 2002, that 20-year span, the AASLD, American Association for the Study of Liver Diseases, coined the term NAFLD, non-alcoholic fatty liver disease. And we stood with that until about 2020, when Dr. Islam came up with the idea that maybe we need to look at the metabolic derangements that we have known about. And maybe we should change the name to Metabolic-Associated Fatty Liver Disease. And now here we are in 2024, a good 40 plus years later. The official name has been changed to MASLD, MASLD, and MASH. And what that stands for is Metabolic Dysfunction-Associated Steatotic Liver Disease, MASLD, and also the more aggressive form, MASH, which is Metabolic Dysfunction-Associated Steatohepatitis. And with the word hepatitis there, it's actually indicating that there is true inflammation going on, an immunologic response that is triggering this. Now, the other part of all this is that we are paying far more attention to the role of alcohol. So while we all knew that alcohol was an important component of this, we now have the MASLD and increased alcohol intake, which we're calling MetALD. All right, and you could see here that there is this continuum of weekly alcohol or daily alcohol consumption. And you could see that as one consumes more alcohol, the steatotic liver disease, and we're not calling it fatty anymore, the steatotic liver disease becomes more alcohol predominant and less of the MASLD predominant. And now for the very first time, when you look at this algorithm, how do we stratify these patients? We are now specifically looking at and asking the question, does the patient meet any of the cardiometabolic criteria? And as you can see, as you identify somebody with fatty liver, you ask questions about presence or absence of cardiologic risk factors. If the answer is yes, but no other causes of steatosis, you then are at the point of saying they have MASLD. If they say, yes, there are other causes, then you may be getting into the metabolic alcohol liver disease portion of this. But I think this is pivotal that we are now raising the bar to ask about cardiometabolic risk factors in a liver clinic or in a primary care clinic. Now, these 5 criteria here, I would say, are pretty basic from a cardiologic standpoint. Are you overweight? Okay, and they give you the guidelines on BMI. What's your fasting glucose or A1C, or are you simply on treatment? Okay, blood pressure or on therapy. So again, the bar is pretty darn low here. Okay. Lipids, or if you're simply on a lipid-lowering agent. So I don't know, Dr. Coulter, if this is like 95% of your clinic. 100%. Okay. But anyway, so this is just really rudimentary of evaluation to look at somebody with cardiac issues. So now the comorbidities, which you're all familiar with. Obesity goes along with fatty liver. And it is that android fat distribution, that belly fat. And these patients are going to be insulin resistant. They're going to have cardiovascular disease. The interesting thing is you develop hepatic fibrosis, scarring, regardless of BMI. There is not a BMI cutoff to say if your BMI is 30 or greater, you're at risk for cirrhosis. You just have to be overweight. And of course, with this obesity and insulin resistance, you get the release of free fatty acids and lipid accumulation. Type 2 diabetes, most impactful for developing fibrosis and getting cirrhosis. We all know the drill here. Poor glycemic control is associated with cellular injury, free radicals, all sorts of oxidative stress. And what I would say and what the recommendations are, every patient with MASLD needs to be screened for type 2 diabetes. Hypertension. Now, I say here, chicken or the egg. Is it you're hypertensive and you develop more fibrosis, or you have fibrosis and underlying liver disease and it triggers hypertension? Not clear yet, but there is a connection with hypertension and being at risk for fibrosis. Dyslipidemia. No question there. I would say statins are safe, but they're underused. Patients are stopped. We get patients that come to us from a good-natured cardiologist to say, should I stop or should I go? And we basically just say, go, and if you feel like it, double the dose. Obstructive sleep apnea is a problem. Cardiovascular disease, the #1 cause of death in patients with fatty liver. I wish I could say it was liver disease. They're dying of cardiovascular disease. CAD, CHF, AFib, aggressive
management is warranted, and chronic kidney disease is seen with increased numbers. I cross out cardiovascular disease because these patients are not being treated. They're not being treated. I know this from my own practice, where 70-75% of our patients have fatty liver. They have hyperlipidemia, they have hypertension, not being aggressively managed. So in the absence of fibrosis, so for a hepatologist, fibrosis is equivalent to your coronary plaque, I would say. All right? Is that okay, Joe? That's all right? Okay. But in the absence of fibrosis, so you just have a fatty liver found on ultrasound or some other imaging, there's increased liver morbidity and mortality, increased all-cause mortality. They're dying of something with a shortened lifespan. And the most shocking, increased non-hepatic malignancies. So you look at progression. How long does it take, right? You see somebody that's 50 and you're wondering, how much more thread does this guy have on his tires? How far is he away from dying? Well, from what we understand, if you have MASH, the more aggressive form, you will progress one stage every 7 years. Okay? So if you meet somebody with stage 2 fibrosis, they'll be cirrhotic in about 14 years. If they have MASLD, which is the slightly less aggressive form, it's about 14 years. But alcohol, small amounts of alcohol, like 1 glass of wine a day, 2 glasses of wine, will throw these numbers completely off, where you could see somebody accelerate and decompensate very, very quickly within a couple of years. Once the patient has cirrhosis, documented cirrhosis, they will decompensate, meaning variceal bleed, ascites, hepatic encephalopathy, anywhere between 3 to 20% per year. And looking at a 15-year span, and we could just focus on the MASH on the bottom part there. Well, first of all, 14% of healthy patients going for screening colonoscopy have MASH. They have acute, or not acute, but chronic inflammation and steatosis. But you could see in the 15 years from 2015 to 2030, forecasting out a bit, the number of cases of advanced fibrosis is at least doubling. So this is not going anywhere fast. There is a lot more disease out there. And when you look at these number of cases of liver-related death to fatty liver, the red line going up, cases of decompensated cirrhosis going up as well. So the future does not look bright here for those patients with fatty liver disease. They're getting cancer and they're dying. Now, what about transplant? So on the UNOS liver transplant wait list for women, and here we are today, go red, talking about heart disease. Women, the #1 disease listed for transplant is NASH or MASH, fatty liver disease. Behind alcohol. For men, alcohol still is the leading indicator, but right behind it, leading the pack, is fatty liver. So we transplant these patients. And you say, okay, we fix it. Well, not so fast. These patients get recurrent fatty liver. The cardiovascular profile does not improve. And we're back to square one, 1, 3, 5 years later. So this is a Texas problem as well. This is an all-county heat map of liver disease mortality from 2009 to 2018. Now, there are very shocking. The West Coast is getting hammered there. Arizona, Florida, but Texas, which we're concerned about, is right in the bullseye here. And why this is multifactorial. But if you just focus in on Texas, liver cancer incidence from 2011 to 2015, you see that the Rio Grande Valley, as well as West Texas, El Paso, is leading the way with the number of new cases. And I would say the numbers have been updated slightly, but Cameron County, which is Brownsville, is now ground zero for fatty liver disease, cirrhosis, and liver cancer for the entire country. And here's the mortality numbers, as you would expect. South Texas and West Texas is leading the way. When you look at liver cancer in the United States, the whole country, and again, this is from 2015, Texas is leading the way with an incidence of about 11.6 per 100,000 people. One thing not to be too proud of. But it's very interesting when you tease out the Hispanic population. Not all Hispanics are equal. I didn't know that there was a Floridian Hispanic, but they looked at this and you could see that the Texas Hispanics have the highest incidence of liver cancer compared to those that are in Florida. So this opens up the door to diet, genetics, family history, but it's interesting, but it's a problem we have to continue to deal with. And this graph here shows that, again, it is probably the Mexican-born, Mexican Hispanic compared to Cuban, Puerto Rican, Dominican, Central or South American. So we are in a unique position to have high rates, but it is a uniqueness to the heritage of the patients we see. And again, you shouldn't be too surprised at this liver cancer mortality when you compare male, female Texan compared to all non-Texans. Texas leads the group. There are more women with liver cancer that die compared to non-Texans, same for the men and all around. Now, an alarming part of this whole story is cancer. And so why this happens in fatty liver is certainly related to insulin resistance. And I would say a lot of the cardiovascular disease you're seeing, the mechanism within the vessel is also due to insulin resistance, decreased adiponectin, and increased leptin. And we are seeing these non-liver malignancies, esophageal, gastric, pancreatic, renal, colon, cholangiocarcinoma, and breast cancer. So again, I'm going to bring up Go Red Day. Here we are talking about women's heart disease, but in the same context, you have to think about their risk of breast cancer. There were two large studies that looked at thousands of patients, and they found that if you have fatty liver, a woman has somewhere around 50 to 70% increased risk of developing breast cancer. These numbers are just unacceptable. And a lot of it comes from this intestinal dysbiosis, your microbiome in your gut. So for a minute, you're going to be thinking about your heart and your chest, but I'm going to force you all to look at your guts for just a minute. The intestinal microbiome is really, I think, the seed of the problem for both cardiovascular disease and liver disease. With all of the alterations in the gut bacteria, the inflammation that is happening there, the byproducts of these other, typically a lot of gram-negative rods, producing these cytotoxins, cytokines, you get bacterial translocation. So the integrity of the gut is disrupted, and all of these toxins are flowing into the portal and systemic circulation and creating havoc around the body. So talking just about cardiovascular disease, and I feel like I'm a little out of place here at the Texas Heart Institute talking about cardiovascular disease, but I will give it a try. So with fatty liver, across the board, increased cardiovascular disease. According to studies from the Framingham group, Fatty liver, MASLD, increases the risk of type 2 diabetes and hypertension. Fatty liver increases your coronary calcium score or risk of having higher calcium scores. 20% risk for any atheromatous plaque just by having fatty liver. Increased carotid disease in patients with fatty liver. When you take high-risk groups, and this particular study looked at diabetics, CAD, cardiovascular, peripheral vascular disease were higher in the fatty liver patients and far more atherogenic lipids in fatty liver and coagulation imbalances. So that is probably something very important to all of you. Now, what about cardiac function? There is greater LV dysfunction with fatty liver, abnormal cardiac energy metabolism. And in one particular study, 30,000 individuals looking at fatal and non-fatal coronary events, MI, CVA, angina, 64% higher in the fatty liver patient. And they have much more AFib and AV block and other assorted arrhythmias. And it all gets down to the gut microbiota here. So high saturated fat diets, sucrose, high glycemic index foods, and processed meats, they are the underpinning of our microbiome and its alteration. And it has been figured out that the fatty liver patient has their own signature with regard to the bacteria that they have and the alterations, which as a result, this altered sort of platform increased coronary artery disease, ischemic stroke, vascular calcifications, and increased clotting. So again, this is hard to walk away from. And again, I am a bit embarrassed to show a picture of a blood vessel here, but bear with me. But in that fatty liver scenario, its interaction with the heart, you're getting vascular inflammation. And I would say, keep it simple, no different than the inflammation you're getting in your liver. Lipid deposition within the walls of the vessels, vascular remodeling, endothelial injury, and hypercoagulability. And here again, these are mechanisms you're all very familiar with, and I'm sure many in this room are studying. With fatty liver getting LV dysfunction, impaired energy metabolism, valvular disease and arrhythmias, and then at the vessel level, hypertension, atherosclerosis, impaired vasodilation, and increased carotid artery intima media thickness. This is all your language stemming from gut microbiome, Western diet, one lane causing liver disease, the other leading to heart disease. But I guess we all have to be quite honest here that this is all related to our diet. And the cost is going to bankrupt us. $147 billion a year on obesity-related care. You're all familiar with that. Kids aren't eating right. There's not enough fruits and vegetables in our diet. Kids are not running around anymore. Adults aren't running around anymore. And think about going to the supermarket. So in 1970, your typical supermarket had about 9,000 unique products. Okay? Current day, over 50,000 different products. And these are not a better zucchini or a better celery. It is sauces, condiments, baked goods, packaged, pre-made foods. And what happens is, and there are people that have spent their entire career studying this, when we as humans have more decisions, more options, it doesn't make life better. We actually become very unhappy when we have more selection, right? You ever go to the store and you have to pick out like 14 different brands of jeans to buy? You don't know what to do. You're confused. Now, you may buy the wrong brand or you may just walk out, but you leave with an unhappy sense. The same thing happens with food. People go to the supermarket and they are confused and they will just buy on impulse. Now, while there is more food, the size of our portions has gone up over the last generation in a sense. So calories are up, exercise is down, eating out is up, cooking at home is down. And I love this cartoon from the New Yorker where this lady just wants to buy a piece of fish. And she has to deal with whether or not this is wild caught, farm raised, lab grown, beach found, or aquarium harvested. This poor lady. I'd go for the Mrs. Paul's fish sticks if I was her. But when I look at our obese patients and I look at fatty liver, for me, fatty liver is just the tip of the iceberg. And underneath are many of the obesity-related complications, the little hearts, or what may apply to all of you, decreased survival, heart disease, stroke, high blood pressure, etc. But what is interesting is that when you poll patients with fatty liver, only 5% know that they have a liver disease. Now, the 1.8 was African Americans, 8.4 were college educated. So 5 seems to be a pretty good number, 5% of the population. But when you ask patients that have hepatitis C, 42% know that, yes, indeed, I have a liver problem. And only 20% of all cases of fatty liver have been diagnosed. So there is a tremendous reservoir of patients with fatty liver out there. I could keep my doors open 24 hours a day and not see everybody that needs to be seen. And sadly, greater than 50% of primary care physicians are unaware of that risk of fibrosis nor the coronary artery disease risks that is associated with fatty liver. And so the most simple thing I could say here is that there is a giant disconnect with patients and or providers that are seeing these fatty liver patients, not realizing that a ticking time bomb is sitting in front of you, be it breast cancer, be it having a massive stroke within the next 2 weeks, or there is intervention, or how do we evaluate these patients? And again, I don't mean to sound sour. I am just telling you my experience of 35 years. There is a massive disconnect. Some would say disconnect, I say opportunity. So with the dead end ahead, as I said earlier, the number one cause of death is cardiovascular disease in these patients. Number 2 is non-hepatic malignancies, and number 3 is liver disease. Now, where do you begin to sort these patients out? So you have to screen them for fibrosis. And I'd like to say this is our stress test. Okay? This is our stress test. So when you see a patient with fatty liver, you have to do a targeted evaluation. What are their risk factors? Do they have metabolic syndrome? Do they consume alcohol? Now, they do not have to be a card-carrying alcoholic to be worried about their alcohol use. As I said, small amounts of alcohol. You come home from work and you have a glass of Chardonnay. I'm not going to complain about that. But in the context of fatty liver, it's a big deal. Family history. Family history. 12 times the risk of having fatty liver yourself, and then household members. I like to say a family that eats together gets fatty liver together. And so this is, without going into all the detail here, a scheme to screen for fibrosis. And we call it NITS, non-invasive testing. Hepatologists are not too creative. But we look at these NITs that we have. And there's something called the FIB4. And you can all look on your phone, maybe later once I'm done. download the FIB4 calculator for your phone. And all you have to do is plug in age, AST, ALT, and a platelet count. It gives you the FIB4 up on the upper right there. And you'll know right away if the FIB4 is less than 1.45, their negative predictive value of having fibrosis is 90%. That's pretty good. If it's greater than 3.25, the positive predictive value is about 65% that they have advanced fibrosis. So right there, 2 minutes, you could stratify Mr. Bob, who's in front of you, with hypertension and diabetes to say, whoa, you're on this side of the equation, you're at risk, we need to do something. So the other thing that we have, which has been really very, very innovative, is FibroScan. This is a sound wave test, focused sound into the liver. It measures the shearing forces and the stiffness of the liver. And we could, in about 3 minutes, find out this score here. It correlates with liver biopsy by about 85% in most cases. So here again, we see a patient, we're evaluating them, we know their risk factors, we'll send them for a FibroScan immediately, and before they walk out the door, we know low risk, intermediate, or super high risk, and we take action from that point. But the problem is we have this disease-centered approach to this problem. We're the hepatologists, just stay in your lane. There's 2 yellow lines, don't cross it. Cardiology is over here, stay within your lane. Endocrine, stay in your lane. Nutrition, stay in your lane. We have to get more to patient-centered. Look at the patient and figure out what their problem is and address all of them, hopefully, under one umbrella instead of fractionating the care. And we have to surround ourselves around this patient. The MASLD patient, hepatology, cardiology, endocrine, primary care, obesity medicine, and surgery. 20 years ago, I was not a big fan of patients going for bariatric surgery. I'm a little bit more of a fan now. It's quite amazing. Behavioral, nutrition, and exercise. We have to take our patient and form a ring around them. Now, here's my Joe's MASH wheel. And this is sort of a bigger representation of primary care, endocrine, nutrition, lifestyle. And this is hard work. Trying to sit down and take a dietary history, where they shop, what they eat. This is tough. This is tough. Our registered dietitian in our clinic, Lauren, is here. And she does a magnificent job, but this is hard work trying to figure out and dig deep. This is more than just a superficial visit saying, what do you have for breakfast? Okay. And then, of course, there's all the hepatology part. Then cardiology is in there with lipid management and really further risk stratifying these patients. And with the treatment approach, we have to avoid alcohol, weight loss. Now, you only need about 3 to 5% of your body weight to be lost to settle down and remove the inflammation and steatosis, okay? Reduced fats, you want to get them on a Mediterranean diet, exercise. This is a case where intense aerobic exercise is probably better than a long walk in the park. Surgery, obviously, gastric bypass or a sleeve will improve weight loss, reverse the diabetes, reverse fibrosis, and it corrects the dysbiosis in the gut, which is fascinating. And medicines, there are a host of medicines that are on the launch pad to address this. Statins, very interesting. They're safe. I would use them. Do not stop. It's interesting that statins may affect the microbiome as well in a positive way. So you get sort of that 2-for-1. Kill 2 birds with 1 stone, maybe a third bird, fix the gut issue. We are looking into fecal transplant, all right? That became quite famous with C. diff colitis, but there may be a role in treating fatty liver and underlying coronary artery disease. And here's just a very complicated slide looking at all of the different mechanisms and medications and therapies that are being looked at. There was one, probably the closest that's going to be to market. It's a medication by the company Madrigal. It's a thyroid hormone receptor beta agonist, which may be the first drug we'll have. And then where heart meets liver. So you take your NAFL or MASLD liver patient, check for metabolic syndrome, do some first-line cardiovascular assessment. They have a family history, glucose, smoking, exercise. Next stage, you get into EKG, maybe carotid Doppler, echo if needed. And then third line, other cardiac imaging that could risk stratify them as appropriate. But again, you see how you could take these fatty liver patients and work them through the evaluation process. And there are already a number of drugs that are more traditionally cardiovascular in nature, fatty liver, obesity in nature, that there is overlap with therapies. I gave statins my own green dot there. I took the editorial liberty there, that there may be hope for the future that statins are going to be beneficial. All right, so what do we do now? Comes down to education. There has to be the realization that this new entity, the new term, MASLD and MASH, are both a cardiac and hepatologic disorder with significant morbidity and mortality. We're not talking minor stuff here. We're talking very, very major disease here. And the education is both for patients, care providers, mid-levels, pharmacists, everybody in the continuum here. Because this is the root of me seeing, and I'm being selfish here for a minute, for me and my team seeing late referrals. I don't think anybody has bad will against the obese patient. They just don't know. And there has to be, in clear as daylight, this connection between MASLD, the liver dysfunction, cancer, and cardiovascular disease. So with that in mind, you have to screen and identify these patients. They have to be identified. And at the bottom here, make visible what is invisible. Make visible what is invisible. We have to identify these patients and appropriately risk stratify them to keep them out of trouble. From a research standpoint, and I believe that there is so much that can be done. Further working on the microbiome, not only for liver disease, fatty liver cirrhosis, and I'm sure there is a lot of work in the cardiovascular literature on the microbiome, but that would be an area to work on. This hepatico-cardiac oncology access, what does this really look like? How much cancer is in patients that have heart disease? How much cancer is in people that have heart disease and liver disease? What is the role of statins? I would think that this would be something we need to look at. The impact of bariatric surgery, a medical economic model on all this, the fractionation of care, and I say really integrated care, really, I mean it, and think of it as earlier, better, and cheaper. And I think the new paradigm, right, that's how we all started, is people that don't normally play together maybe have to be on the same team. My hero, Joe DiMaggio and Ted Williams. Boston versus the New York Yankees, come on, whoever would see these guys together? But I think you have to look local, regional, national, international. How do we address this disease and pull everybody together to work on the same team? And lastly, I don't think it would be fair to not talk about AI. You know, where does AI fit in all this? And I think with all of the data out there, all of the raw material to try to sift through, trying to predict fibrosis, cirrhosis, what are cardiometabolic risk factors? How do we just allow a computer to sort of pull this all for us? How do we standardize the way pathology is looked at? Scouring our EMRs, looking for early signals that may indicate this person is at risk for either a cardiac event, a cancer, or some sort of liver complication. With all the imaging that we have, there's got to be a way that we could pull this all together. Real-time biomonitoring, these wearable devices. I think, there's nothing on my watch that says my latest ALT or bilirubin, but maybe we could work on that. But I think we have to look at that. And then, of course, there's so much which I didn't even talk about, the epigenetics, the genetic profile of patients that are at risk for both cardiovascular disease, cirrhosis, and liver cancer. So I think I'll end here to say the two Joes here. I know that Dr. Rogers is going to be, he's going to check the liver, and I promise you I'm going to check the heart. And a very, very big thank you to all of you.